Now, these are my disclosures. First of all, as was previously pointed out by that wonderful lecture from Dr. DeBar, this is a big problem, and I would like you to focus on a couple of things. Number one, the most preventable cause of death in hospitalized patients is venous thromboembolism. And number two, what is the standard of care for a surgeon? The standard of care for a surgeon has to include, in addition to doing a proper procedure, to protect his or her patient from the number one preventable cause of death after surgery. There's no other cause of death after surgery that you can so readily prevent as venous thromboembolism. And it's a big problem. You can see from these figures from Europe, it's a very big problem. In the United States, 100 to 300,000 people have been judged to die every year, and as was pointed out by Dr. DeBar, many more patients than some of the other diseases, accidents, and so on and so forth. Now, before we get into the risk and so forth, what are the many faces of venous thromboembolism? I know sometimes some of our orthopedic colleagues consider only symptomatic and fatal pulmonary emboli during hospitalization after surgery. Everything else is sort of not as important. And that's not really correct. There are so many important things. First of all, there's pulmonary emboli. And for example, this is a patient that presented to Duke University with non-productive cough, mild wheezing, shortness of breath, and back pain. Common symptoms. And this patient developed a DVT and a massive PE and died 3 days after admission to intensive care. You can see here the clots blocking both pulmonary arteries. And, oh, by the way, the patient did not receive prophylaxis. And again, this is from a famous university. It happens all over the world. It happens everywhere. These are very complicated patients that come in with all sorts of problems. And unless you develop a very high degree of acuity, then you will miss these problems. And people say, well, you're always talking about pulmonary emboli. And I said, that's one of the few things that could kill the patient. Your patient postoperatively develops a tachycardia. They develop a little shortness of breath on exertion, but when they sit down, they're fine. You always have to beware. This is a very occult problem, and it's particularly bad in young people because young people have great cardiopulmonary reserves, and they may not show the effects of even a big pulmonary embolus until they have that final event. Venous thromboembolism is another problem. Symptomatic venous thromboembolism, of course, it can be life-changing. It can be a lifelong disability from a variety of problems requiring taking drugs and so on and so forth. And occasionally you will have a situation like this develop with venous gangrene. It doesn't happen very often, but when it does, and in this lady's case, she suffered fatality as a result of it. Another problem is a paradoxical embolus. 25 or 30% of us have a patent foramen ovale between the left and right atrium. It's non-functioning. But if the right atrium dilates because a clot comes into it, then it opens up that opening. And here you see it. And the clot sticks in it. It can break off. And I've seen it go to the brain, to the arms, to the legs, to the superior mesenteric artery. And all of those, there are other faces of venous thromboembolism, and the first thing you want to do when you see a patient like this, besides doing an echocardiogram, is to do a risk assessment. Now, post-thrombotic syndrome. It's a common event. It's caused by both symptomatic and asymptomatic deep vein thrombosis. Patients have leg pain, aching, swelling in the early stages. Late manifestations include skin changes, a variety of skin rashes, and sometimes eczema, brawny edema, bronze discoloration, varicose and spider veins can be seen. Venous ulceration is the end result, along with venous insufficiency induced lymphedema. Now let's stop. Stop right here. Time out. In the current chest recommendations, there's a very flawed recommendation based on the SOX trial. The SOX trial is an extremely flawed trial, and I believe that it does a great disservice to those of us that spend our lives treating patients with deep venous insufficiency and a post-thrombotic syndrome. The current chest guidelines say that therapeutic stockings do not prevent the post-thrombotic syndrome. It was based on a trial where the patients were never even observed as to whether or not they could wear the stockings. They didn't keep a diary. There are many, many problems with that. And those of us that see venous thromboembolism, what happens, patient goes to the emergency room these days, they get put on sometimes a pill and call your doctor, so then they come in to see us and they want to find out, they've been on this powerful medication, whatever it may be, and their leg's still hurting. It's still swelling. It's still tender. Well, what's the first thing we do? We put them in a good therapeutic stocking. And then when we see them by the next visit, they're almost always better. Now, if you read the fine print, remember you've got to read the fine print. Do not stop with the conclusions. Read the fine print. And if you read the fine print in chest, it will tell you that they do recommend a trial of therapeutic compression stockings may be indicated for pain, swelling, or tenderness. Remember that. I have so many patients that come to me and said, I went to my doctor, and my doctor said, the latest guidelines say stockings are out. And that's just not true. And here's a typical thing that happens over time. The patient had a clot in the leg after hip surgery and eventually developed post-thrombotic syndrome with venous insufficiency in one side and also venous insufficiency-induced lymphedema. Look at the swelling of the toes and between the toes. And time out. Please don't ever, ever put an ACE bandage or a stocking on that leg, because that will not control the swelling. That's a whole different subject, but you have to use short stretch compression. You have to use short stretch bandages, you have to use even Una boots to get started, and you have to follow up with Velcro devices that will help to keep that swelling down. And without that, those patients will never get better. This patient's been treated for up to 10 years until we started to treat her properly with short stretch compression. It didn't heal. And here's another case. This is a real case. 38-year-old male suffered a leg fracture and developed a major DVT while in a cast. This is his leg 10 years later. The ulcer first appeared 2 years previously and failed to respond to treatment, due in part to the poor compliance of the patient once the ulcer appeared. Sure, blame the patient. It's not the patient's fault. This is a post-thrombotic syndrome from DVT from 10 years ago after a fracture in a cast, and it has to be treated with appropriate compression. And this is a life-changing event for this patient. And believe me, those of us that see these problems realize that this is another very important face of venous thromboembolism. So while I'm telling you that the reason that you should be doing all the things that all of us are telling you is to prevent hospital deaths and postoperative deaths, that's fine. But you also want to prevent the many faces of venous thromboembolism, of which this is one. Now, the risk assessment is interesting. I had the good fortune to work with Maxwell Borough, who was a community surgeon from Somerville, New Jersey Community Hospital. It was affiliated with Seton Hall University. And he did some very early experiments with venographic endpoints. And this is 1981. He showed us how the incidence of positive venograms postoperatively went up as the time of surgery went up, as the age went up. But the blockbuster, and not to be forgotten, if you forget about this data, you've got to relearn it. 66% of patients who had a past history of a venous thromboembolism developed a clot postoperatively without prophylaxis. And that is more powerful than cancer. That's more powerful than any other risk factor, is a past history of thrombosis, and related to that is a family history of thrombosis. Stop. Time out. Please don't ever, ever, ever see another patient without asking them, have they had a past history of a blood clot? Interrogate them about that. And now we even know that superficial blood clots, if they're close to the saphenofemoral junction, may be just as important as deep venous blood clots. And the other question, almost never asked, is what? Is there a family history of thrombosis? Not just mother, father, sister, brother, but first, second, and third degree siblings. And I would like to tell you that I have a website, venusdisease.com. You can contact me through that. Everything that I'm saying, I will be more than delighted. And I've had people from all over the world write to me, and I will send you the papers. Please, that's the most frequently missed risk factor that turns a low-risk procedure into a nightmare. Now, as important as that, those early beginnings of Dr. Boro, which really gave me the idea for the risk assessment, until my fellow came into my life, we had this risk assessment, and we were looking at it and looking at it. And Dr. Juan Arcelas and Dr. Sandy Candosia, who was a fellow at the time, a resident in medicine, they got together, and at my hospital where I was chief, they studied 1,000 medical patients and 1,000 surgical patients and reported the results. And they put this thing on the map. And it went on, and then later, thanks to the University of Michigan, and Vanita Ball and her colleagues and Thomas Wakefield, then that's where the big article came, and that's why then one other thing happened. At the 2012 Chest Consensus Conference, it so happens that out of millions of people in the world, they asked Juan to be part of the committee. And Juan immediately introduced them to the 3 articles of that time. They were very good articles about this risk assessment. So when I tell you that I wouldn't be here without Juan, there is a certain element of truth to it, and I believe in divine intervention, and he represents that. And that's to improve care around the world. It's not about me. It's about improving care around the world for people of all disciplines, all cultures, all nationalities, to improve the care of those patients. And that's why this is successful. And what it involves is assigning a point value to each risk factor based on the literature to start with, Dr. Boro's work to begin with, total the points to obtain the score, correlate the score with the 30-day real VTE events, no screening here, real VTE events, and in addition to that, obtain a VTE rate for each score, and always balance the rate VTE versus bleeding. Administer prophylaxis according to VTE risk, type, duration, and validate the results for specific populations. Oh, stop. In the United States, there's a National Surgical Quality Improvement Project. And that's where a hospital will enroll 1,500 patients over a year, and a dedicated nurse researcher will track 23 complications over the 30-day period. Are you ready for this? They don't record past history of thrombosis. Did we forget about Dr. Boro already? They don't record family history of thrombosis. They don't record use of prophylaxis, type of prophylaxis, duration of prophylaxis. And there are 5 million people in that database. So when you look at those studies saying what the DVT rate is, please look at it with a jaundiced eye, because it's flawed data, because it's incomplete. And I would contend to you that retrospective data collection is flawed as far as DVT risk goes, because if you're not there and you don't look the patient in the eye, then you don't know that that question was asked. And oftentimes nobody asks these questions. We have a solution for that, which came out of my next generation fellow, Dr. Alfonso Tafur, that came into my life, and he helped us develop a patient-friendly form that we have the patients fill it out now. If you go to the dentist, you have to fill out your history. Well, why wouldn't you do that to go in and have an operation to prevent the most preventable cause of death after surgery and the most preventable cause of death after hospitalization? You wouldn't be asked about your history? And somebody can't sit there for a half an hour asking you all those questions. But if the patient fills out the form and then it's checked, then that will work, and I'll show you that. Now, the original risk assessment model is here, and there's a number of risk factors on this. And you know, people have tried all over the world for years now. Oh, well, let's simplify it. Let's just look at the high points. Sam Goldhaber, Kuchar, let's just look at the low-hanging fruit. Come on. You're going to have a surgical operation, and you want your surgeon to say, well, we're not going to investigate everything about you and your family. We're just going to hit the high points and I'm a good surgeon. You won't have any problems. Right. The collection of appropriate risk factors and the evaluation of an individual patient is complex. It's not easy. Now, we've made it easier by doing a variety of things, and one of those is the patient-friendly form. But let's just talk about the risk factors associated with venous thrombosis, basic assumptions. The likelihood of developing a thrombosis depends on the number of risk factors. As they go up, the risk will go up. It also depends upon the strength of each risk factor. For example, abdominal operations for benign disease are associated with around a 20% incidence of VTE, and so we give that surgery a score of 2. If the patient has cancer, we add 2 for the cancer because their risk of DVT is almost double. And that's how the score works. The same thing works by age. Now, to do this right, stop. Please don't get the idea that this is easy. This is not easy. However, what you're trying to do is prevent deaths in your hospitalized patients, and you have the power as surgeons to prevent the #1 preventable cause of death after surgery. What great power you have. But it comes with a price. You've got to do this score. Now, you don't have to, and there are many roads to Rome. You don't like the Caprini score, then do something else. But you must account for all of the risk factors. And I don't care what you call it, but you must account for inflammatory bowel disease, congestive heart failure, family history of thrombosis, personal history of thrombosis, blah, blah, blah. Now, you want to do that on my form, that's fine. You want to do it without it, that's fine, but you have to do it. And so the initial form is completed by the patient, then the healthcare professional in 5 minutes, we've found, can calculate the score, and then the score needs to be revised during the hospital stay. Suppose you have an operation and you leak, and there's a perforation, and you have to be drained, and you have infection. Now you have a central line. You had to have a reoperation and a colostomy, or an ileostomy these days. You have to add all of those factors, and by the time you go home from the hospital, you have to have a final score that calculates your overall risk. Why? Because another terrible bad habit has happened, and it's not been addressed properly by CHEST, is when the patient ambulates or when the patient comes home from the hospital, you can stop their prophylaxis. That is utter nonsense. And one of the most beautiful things, talk about inspirations and divine inspirations or whatever, has been the Riete database. The Riete database is now has over 75,000 patients with DVT collected by doctors from all over the world, and it tells us about these things and what we need to do. And Juan, when he was with us, published this study showing that 77% of people got their blood clots after they went home, and 55% after prophylaxis was stopped. The Svetland study of 947,000 women with breast cancer, with breast disease, and they were followed for 6 years. The risk of a death from a thrombosis, risk of thrombosis occurring in patients, and 250,000 of them had surgery, was 70-fold higher, and it persisted for almost 100 days. And so, going home from the hospital, is it easy? Is it easy to give somebody shots for 30 days? Well, of course, but we didn't say this was easy. But what are we trying to do? We're trying to prevent death. We're trying to prevent death and disability. Now, chart review. A very brilliant young man, Christopher Panucci, has published many articles and studied this very extensively, and this is from a presentation at the American Venous Forum, where he compared chart review in a number of patients to face-to-face. And as you can see, history of, and you have to include this. There's thousands of women around the world that have had stillborn infants, unexplained, recurrent spontaneous abortions, premature birth with toxemia, growth-restricted infants. They may have the antiphospholipid antibody syndrome. And if you don't take that history, you won't know who to test. You can't test everybody. Now, in chart review, 0.6%, 13.9% face-to-face. Same thing with history of DVT, 6.3% chart review, 12% face-to-face. Oh, stop. That is, unless the chart review is in the NISQIP database, where it's 0 because they don't track history of VTE. Astonishing. 5 million patients are in that database. I've written to them every year for the past several years. I've been a speaker at their program a number of times, and we still have, and yet I'm supposed to stand there when the residents come at the University of Chicago and they come to spend time with me, and I'm teaching them about risk assessment and to ask these questions. And I remember one of them, a very bright student, said, well, Dr. Caprini, that's all fine and good, but how come the American College of Surgeons doesn't recommend that? Because they don't collect that in their National Surgical Quality Improvement Project. I didn't have an answer. Now, family history of thrombosis, 5.2%, 3 times higher face-to-face. And I can assure you, if you give the patients a form, if the form is electronically on their, they can get it on their iPad or their computer, and they can fill it out even before they come into the office, you will have good data. So here's the form. And this is a form in English. It's now been published in Thrombosis and Hemostasis Open. And the patients fill this form out. And the way this was done is we got a group of people, and we interviewed them and had them fill out the form and found out what problems they had. And then from that we adapted the form, and then we had another group of people who filled out the form, and then they were independently interviewed by trained physicians, and they were compared. And it turns out that there was a very high level of agreement between the physician completed and the patient completed form. There were 4 problems. They didn't often recognize the family history until you pointed it out to them. How many times have you talked to a patient and they say, well, how about your family? How's oh, everybody's fine. Everybody's not fine. You will ask, well, how about your mother? Well, my mother died of a blood clot, or I had an aunt that had this or that. Is that easy to extract all that information? No. Do we have time to do all of that? That's why it's not being done. But to put that in the patient's hands is a help. We also had to calculate the BMI for them. They didn't understand pitting edema, and the obstetrical history is almost always missed. But you can't miss that. These other risk assessment tools that don't have family history of thrombosis or obstetrical misadventures, every time a patient is evaluated with one of those forms that has one of these problems, you've underscored the patient. And that may make the difference in some cases between life and death. Now, in the United States, we've done, I think in general, in my opinion, with the Caprini score, it's improving, but I've had much more support from the Middle East, from Asia, South America, and many places in the world. And the Americans are very slow to adopt things, and especially you're never a hero in your own hometown, so I understand that. But Boston University and the University of Michigan are exceptions. Boston University had a success story, and this is what you have to do. You have to have standardized electronic physician orders, and it was combined with postoperative mobilization. Mandatory risk stratification. So you couldn't sign the orders until you signed off on prophylaxis. And you, of course, had to do the risk assessment. They compared the outcomes before and after implementation, and the VTE incidence decreased by 84%, the pulmonary emboli incidence decreased by 55%, and the VTE outcomes declined. And this wasn't easy. They divided people into 5 categories, 0, 1 to 2, and 3 to 4. And you'll notice in those categories, they included anticoagulants because at the time, the Americans required the SCIP protocol, which is the Surgical Care Improvement Project initiative, that every surgical patient had to get a dose of anticoagulation within 24 hours of surgery. And then what? They never said. So that's what people started to do. And so they had to put that in this because they did it at that time. And we'll get back to that. Then if the patient was at risk. Now, would you please evaluate what you think of this statement? Patients who are at risk for thrombosis should be treated for the period of time shown in randomized clinical trials to be efficacious for preventing venous thrombosis. And I'm going to show you, since 1975, over the last 40 years, in 43,000 patients in 100 and some trials, it's all been shown, a week of prophylaxis. And so that's what Boston did. So they didn't care if the patient went home in a day. If they were at risk, they got injections of low molecular weight heparin for 7 to 10 days. And if they had a score of over 8, 30 days of prophylaxis using low molecular weight heparin. And Juan is right. I remember with Michael Hume, who was a chief of surgery at the Deaconess Hospital in Boston, we made a video for nurses in 1977 how to inject subcutaneous heparin. And we have been doing that for a long time. Now, of course, this was in some very fancy Boston neighborhood where all the people could afford this, right? No, this is an indigent hospital. Some of these patients didn't have homes. But what the hospital did is it worked out with a drug company to provide the drug to everybody that had the high score that needed it. And they worked out a system, and they're still doing that. And it really works, but it's not easy. And here are the results, you can see. And the green line is the average that reported in comparable hospitals, and you can see where they started, and you can see where they are now. Now, I'd like to talk about a dear colleague of mine, Professor Nimeri, and he's from the Sheikh Khalifa Medical City in Abu Dhabi and the UAE, and he and I have been talking and working together for years and years. A wonderful investigator, done a beautiful job, and here is his latest work, and I decided I'd like to show it because it's very apropos. And these are 1,152 bariatric surgery patients operated on between 2010 and 2016. The VTE rates decreased from 2.2% in 2011 to 0.3% in 2016. Mandatory Caprini Risk Assessment on admission. Pneumatic compression devices and unfractionated heparin upon anesthesia induction. Low molecular weight heparin, 40 milligrams BID during hospitalization for a score of less than 5. If the score was 5 or more, then they got 60 milligrams BID and then adjusted with a factor 10 assay after the 3rd dose. No increase in bleeding complications. And doing this, the Bariatric and Metabolic Institute VTE management resulted in dramatic lowering of VTE rates that now approximated the NISQIP program. I don't fully understand how. I think the NISQIP program is missing a lot of data because I don't believe they're as good as with Dr. Nimeri. I think he's way ahead of them, in my opinion. Now, here's another story, and I think that Dr. Fahad has also been, another one of his studies is just presented, but here's another study, 1,241 VTE events in medical and surgical patients using the Caprini score. And stop the music. You all know how hard it is to get people to do risk assessment. Imagine having multiple risk assessments in your hospital. It'd be a nightmare. And so a lot of hospitals, and it's been very successful, there's now, we're closing in on 80 centers around the world and closing in now on 250,000 patients. A lot of these hospitals have gotten this thing to work. Why? Because it's very comprehensive. Excuse me. Appropriate prophylaxis was used in 63% of the surgical patients and 34% of the medical patients, and the mortality was 14.3% overall. Appropriate prophylaxis was associated with a 4.11% absolute reduction in mortality, and prophylaxis after discharge seen in 89.4% of survivors with 71.7% adherence. Very similar to Boston. Authors emphasize the need to improve utilization of prophylaxis. Now, I've heard this from the orthopods forever, and they're the most wonderful surgeons. I had a bad leg, and they did a beautiful job, but they just don't seem to get it. And they say, you know, Dr. Caprini, we don't need your risk assessment because all of our hip and knees are high risk. That's all we need to know. Wrong. The higher the level of risk, the more that will predict not only DVT and PE, but it'll also predict mortality and non-DVT related complications. There's data for all of that out there, and it's growing fast. So you've got to analyze the risk of your patient, because some patients are very, very, very risky. And if it comes to a quality of life improving operation and they have a significant enough chance of a death afterwards, you may tell them they may not want to have the operation. Now here's another study that Christopher Nucci has done. This is the agony and the ecstasy study of the Caprini score so far. The ecstasy is that he took 13 of the purest studies out of over 70 studies and calculated a meta-analysis of the value of the Caprini score, the value of prophylaxis, and what happens when you don't use prophylaxis. Left out Michigan, left out. Michigan's been using this in 2009. Boston University, that beautiful state, left that out because it wasn't pure enough for the meta-analysis. So that to me was the agony, because those places, as well as some places in the Middle East, that represents the real world. That's what's going on out in the community. And it's fine, but you know, you got to remember something, and remember this about guidelines, especially you young people. You're not making a soup recipe. You're not following the recipe to make clam chowder. You start with the guidelines, and then you have to use clinical experience, the experience of your mentors, what you're taught, and then actually you have to try it in practice. And if it doesn't work, you can't keep doing it. You can't say, well, I got to do it because it's in the guidelines. It's not working, but I got to do it. Or the patient comes in and they have a disease, and you say, oh, there's a cure for that disease now. I just saw it in the New England. But I can't do that to you because you were an exclusion criteria. Get with it. We've got to talk about real life. Anyway, in this study, the beauty of this study shows you what happens if you don't use prophylaxis. As your score goes up, your DVT rate goes up to 10% if the score is over 8. And he did show that with scores of 6 or less, that involved 75% of the patients and no significant reduction in the VTE prophylaxis, using his very pure little segment. And we don't even know how many of those risk assessments were complete. We don't know how many of those questions were all answered. And for God's sake, we don't know if anybody with if the family history was well represented, if the obstetrical misadventures were well accepted. He's already presented the study which shows that with chart review, they're not. And now, this is supposed to be the gospel? So it's a good little guide, but remember Dr. Borrow. Remember the most significant risk factor after surgery is a past history of venous thrombosis, as well as a family history of thrombosis. And the meta-analysis is just a start. And I was just recently kicked out of a case in Illinois where I was trying to defend, I was for the prosecution, a lady that had an operation and didn't get prophylaxis and died. But the score didn't reach 8, so they said, well, the score didn't reach 8, so she just got 2 doses of anticoagulation during the hospital, nothing afterwards. So that was the standard of care, and since you've published and you're on the internet showing that you need a score of over 8 to give 30 days of prophylaxis, then you're out of the case. And you don't just go by the score. This isn't the soup recipe. You go by the patient. The number 1 risk factor is history of thrombosis and family history of thrombosis. And I believe if they have that, they should be protected for 30 days, at least. You always have to consider the risk of bleeding complications. And here's a beautiful meta-analysis. And what this shows is that the incidence of complications using anticoagulants, low molecular weight heparin or unfractionated heparin, are not insignificant. But down here, look at this blue line, the controls. And look over here, most of these are minor problems. Did these patients die? If they had a wound hematoma, mucosal bleeding, or discontinued prophylaxis, they didn't die. And look over here, subsequent operation. Control group, 0.7%. Excuse me. Low molecular weight heparin, 0.3 more. Come on. Is that worth saving a life? And I'll show you how that can save a life. If you don't use prophylaxis, thrombosis occurs, then you have to give anticoagulation, and more bleeding can occur as a result of it, giving the anticoagulation. And here's one of the fathers. And Professor Kakar, God rest his soul, he died this last year, and he was the one that in 1975 organized this trial 4,000 patients from 28 medical centers in the United Kingdom and Europe. And what he showed is statistically significantly lowering of fatal pulmonary emboli and, of course, DVT using small doses of heparin after surgery compared to placebo. And oh, by the way, this was fibrinogen scanning with a venographic endpoint. So he had hard endpoints. And a lot of people criticized him, and they criticized him for a number of years. And I remember that. He was subjected to a lot of criticism. And first of all, it was culturally, how could you give a surgical patient something that's going to cause them to bleed? What are you, out of your mind? But then along comes Rory Collins, an Oxford scholar, in 1988, and he puts together 70 more trials that had the same design as the KCAR trial. And what did he find? 13,000 more patients. Aha! The incidence of fatal pulmonary emboli was reduced by a relative risk reduction of 66%, from 0.9 to 0.3. Overall pulmonary emboli were reduced. But guess what? There was no increase in fatal bleeds. 6 in the control group, 7 in the treated group. So, stop. The administration of anticoagulants to the surgical patient can prevent fatal pulmonary embolism without increasing bleeding deaths. It's a fact. Now, no surgeon likes to have bleeding afterwards because, you know, that's sort of a mark on their skill and their technique. Come on. Get over it. If you give the anticoagulant properly, even if they bleed, you may save a death. So, apples don't fall far from the tree. A.J. KCAR and Sylvia Haas in 2005, 67 more centers. Patients received low molecular weight heparin or unfractionated heparin. This was another low molecular weight heparin company that wanted to prove their drug was better, and they used autopsy-adjudicated fatal pulmonary emboli as the endpoint, the ultimate endpoint, the Grim Reaper, the pathologist in the autopsy room. And look what they found. And by the way, 21% of these patients were orthopedic non-joint replacement, all kinds of surgical patients. 0.1%, 1.4, 1.5, regardless if you gave them heparin. So giving a high-risk patient or giving a patient heparin or low molecular weight heparin postoperatively statistically significantly helps to prevent them from dying. Very tiny incidence of death. And by the way, there were no deaths in the series from anticoagulant bleeding. Oh, did I mention? Forgot to mention. 28 trials, KCAR, 70 more trials, Rory Collins, we're up to 90,000 patients, 67 more centers in the 150 range. From 1975 to 2005, 43,000 patients, 160 centers. Oh, anticoagulant prophylaxis was given for 1 week. There's the efficacy. The efficacy over almost 4 decades, 3 decades for sure, shows us we've got to give the patients at risk 7 to 10 days of prophylaxis. Back to the SCIP program, the Surgical Care Improvement Project, giving that dose of anticoagulants within 24 hours of surgery unless the patient were high risk of bleeding. If you didn't do it, it was a Joint Commission mandate. The hospital could be sanctioned. Along came the veteran study, Altom, 2012. He studied 30,000 patients in the VA system. 89% of patients got their shot, 11% didn't. No difference in VTE events. And oh, this is shocking, isn't it? 1 dose of anticoagulation does not prevent venous thromboembolism in the patient at risk. Hello? How can we take all of history and throw it away? And yet my dear friend, who I dearly respect, Bill Gertz, in charge of the Chest Consensus Conference. Now, this is 2008. This is 3 years later. For patients undergoing major general surgical procedures, we recommend that thromboprophylaxis continue on discharge from the hospital. What? Where did that come from? Yeah, they discharged from the hospital back in the 70s and 80s when they were there for a week, but not in 2008. And shame, shame, shame on 2012. They didn't amend that protocol. And why wouldn't our government say that we're giving that dose within 24 hours of surgery to get prophylaxis started? But remember, you've got to give it for the period of time shown in clinical trial to be efficacious. We have, over 4 decades, 160 centers, 43,000 patients, where we've proven that it's a week. How can you all of a sudden get up and make some pontificate that it's going to be for a day? So what happened? The skip protocol went away. They rescinded it. But they didn't replace it with something more meaningful. And now, let's turn around to 2017, where hospitalizations are 1 to 3 days. 779,000 patients followed for 30 days over 5 years. And in this study, multiple centers, by this time, by 2017, everybody's getting prophylaxis, practically, over 90%. But the DVT rate has increased, the PE rate has increased. Why? Because they're just getting it for a day or two. Can I make this case any stronger? Now, what you see up there is a picture I've taken of a typical United States university academic first-class, first-line medical center guidelines on venous thromboembolism. And I'd like to read it. Pharmacologic prophylaxis should be continued for at least 7 days. That's good. Comma, until hospital discharge? What? Or until the patient is ambulatory? What? Or in selected cases for an extended period of time as deemed appropriate. The nurses oftentimes will say, you know, I have to give you this shot in the abdomen, but it hurts. But if we'll just get up and walk around, I don't have to give you the shot. What, are you out of your mind? What happens when you ambulate a patient? You decrease that risk factor associated with immobility. Does that change family history of thrombosis, personal history of thrombosis, inflammatory bowel disease, congestive heart failure, blah, blah, blah? Good God, I sound like a politician. But it does nothing for those underlying risk factors. Patients who need prophylaxis need prophylaxis. God willing, we want to get them to ambulate because ambulation will prevent them from having additional risks for being in bed. Ambulation has no effect on existing risk factors, such as cancer and history of VTE, and only decreases the risk associated with immobility. The statement that anticoagulant prophylaxis should be continued when the patient is ambulatory is not data-based. Shame, shame, shame on us. Boro, just want to remind you, the more you don't know history, the more you got to go back and repeat it. Key points. Family history of VTE, and by the way, in the United States we have up-to-date, which now all the millennials, right on their phones, will look up up-to-date. You go to family history, beautiful dissertation by a magnificent hematologist from Harvard, blah, blah, blah. It's not up-to-date. This is up-to-date. It's based on the Zoller study and the Bessemer study, and they've been out for 4 years. The relative risk associated with a positive family history was of similar magnitude as the risk associated with a genetic risk factor. So if you're operating on a patient, and that patient has a family history of venous thrombosis, but no personal history, that patient is as much at risk as if they have a factor V Leiden, a prothrombin gene mutation, protein C, protein S. Positive family history increased the risk of venous thrombosis more than twofold. And remember this, the VTE risk increased not only on first-degree relatives, but also second- and third-degree relatives and non-biologic relatives, 183,000 patients. So, my dear Chairman, in conclusion, risk assessment using the Caprini score. Utilize the patient-friendly form plus verification. Avoid chart review. Face-to-face critical. Update the risk assessment as you go through the hospitalization and at discharge. Provide prophylaxis for at least 1 week with a score of over 5. Extend the prophylaxis for at least 28 days over 8. And lawyers, are you listening? Cancer, joint replacement, prior VTE, even if the score is less than 8, I believe should receive 30 days of prophylaxis. And if you look carefully at 2.6 in the 12 Chest Consensus Conference, including the Botaro meta-analysis, you will discover that they actually validate that, but they don't emphasize it. Continue prophylaxis for as long as the risk is ongoing, immobilization, infection, cast, and rigid braces. Remember what we're trying to do here. We're trying to eliminate the #1 preventable cause of death in hospitalized patients. We're trying to prevent the #1 cause of death after surgery that's preventable. And I would like to tell you what a great honor it has been to come here and address this audience, as well as all of the people from around the world. And also, again, thanks to my hosts. Thank you very much.